This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Hi everyone. In today's lecture, we're going to talk about mitochondrial disorders. Have you ever heard of them before? A lot of people haven't. I didn't know what they were either until about 20 years ago when my nephew Cody was diagnosed with one. He was only 11 years old at the time. We're going to talk a bit about Cody and his illness in today's lecture. As you might suspect, mitochondrial disorders occur when mitochondria fail. These specialized compartments can be found in all cells in the body other than red blood cells. Mitochondria create over 90% of the energy that our body requires. When the mitochondria fail, energy stops being generated inside the cell, which can cause cell injury and cell death. Eventually, whole systems stop working, causing debilitating effects to the individual. The most vulnerable cells are those that need the most energy to function, such as in the heart, brain, and skeletal muscles. 1 in about 5,000 people is believed to have a mitochondrial disorder. There are many different types. In fact, over 40 have been identified. These disorders are primarily expressed in childhood, but adult expression is becoming more and more common. Mitochondrial disease is hard to diagnose because it affects each individual differently, and most individuals develop normally until their first symptoms appear. Due to lack of awareness, mitochondrial diseases are also commonly misdiagnosed. The most common misdiagnoses include chronic fatigue syndrome, fibromyalgia, atypical cerebral palsy, and various seizure disorders. Current diagnostic methods include clinical observation, laboratory evaluation, brain imaging, and muscle biopsy. However, there are no known cures, and very little is known about the neuropsychological functioning of these individuals. In today's lecture, we'll discuss the symptoms and causes of mitochondrial disorders, what the mitochondrial disorder MELAS is, and what types of brain pathology and neuropsychological deficits are associated with it, how symptoms and neuropsychological patterns of performance compare in a family with the same mitochondrial disorder, and how these disorders are generally treated. Let's start by examining some general symptoms found across most types of mitochondrial disorders. Now, not all individuals will show all of these symptoms, but the most common ones are as follows: loss of motor control, muscle weakness and pain, gastrointestinal disorders and swallowing difficulties, poor growth, cardiac disease, liver disease, diabetes, respiratory complications, neurological problems and seizures, vision and hearing problems, lactic acidosis or lactic acid buildup in the muscles, developmental delays, and susceptibility to infection. Mitochondrial disorders result from either inherited or spontaneous mutations in mitochondrial DNA, which you inherit from your mother, or nuclear DNA, which you inherit from both parents. In most instances, the parents are unaffected carriers, meaning they have no idea they are passing this on to their children. And if multiple children within the same family are diagnosed with a mitochondrial disorder, variation may be seen in terms of organ systems affected and associated behavioral symptomatology. How is this possible? Well, when DNA divides in the developing fetus, Some cells may receive more defective DNA than others. With successive cell divisions, the defect may become more concentrated in certain organs. Some organs may be affected, but others might not be. This process is random, which explains why members of the same family with the same genetic mutation may exhibit different manifestations of the disease. These same family members might also first exhibit symptoms of the disease at different times. It's believed that although patients with mitochondrial disorders harbor the defective mitochondria from birth, they initially present as symptom-free because their energy output, although abnormal, is still sufficient to meet the body's demands. It's when the output of the defective mitochondria can no longer sufficiently meet heightened energy requirements that the symptoms start to appear. This could happen at different ages for different family members. Deficiencies in mitochondria are not only tied to mitochondrial disorders, but also to disorders such as cancer, heart disease, diabetes, Alzheimer's disease, and Parkinson's disease. Okay, now that we've talked a little bit about mitochondrial disorders in general, I'd like to tell you about a specific mitochondrial disorder called MELAS. MELAS is an acronym for mitochondrial myopathy, so muscle weakness, encephalopathy, so brain and central nervous system disease, lactic acidosis, the buildup of lactic acid in the muscles, and stroke-like episodes. MELAS was largely identified in 1975, though Stephen Pavlakis and colleagues identified the stroke-like episodes in 1984. Although 17 different mutations can cause MELAS, 80% of all cases result from the A3243G mutation in the mitochondrial DNA. Confirmation of MELAS is acquired through genetic testing, blood tests that reveal the presence of high levels of lactic acid, and a muscle biopsy that shows the presence of ragged red fibers, which is a trademark of this disease. The age of onset typically ranges from under 2 years of age to 40 years of age, with most patients presenting with symptoms between the ages of 5 and 15 years. As I mentioned earlier, one hallmark feature of this disorder is normal development until the first symptoms appear. Physical symptoms of MELAS can include short stature, diffuse limb weakness, exercise intolerance, sensitivity to extreme temperatures, nausea, and vomiting. Neurological symptoms can include seizures, headaches, memory impairment, vision and hearing loss, and stroke-like episodes. So what are stroke-like episodes? So these manifest a lot like typical strokes. Trouble walking, speaking or understanding, maybe paralysis or numbness in the face, arms, or limbs. Although we haven't talked about strokes yet, typical strokes relate to the vasculature of the brain, so the arteries. Some researchers believe that stroke-like episodes do not correspond to vascular territories in the same way. Instead, they think that these episodes may be cellular in origin and result from the defective mitochondria's inability to respond to periods of high metabolic demand. However, other researchers argue that blood vessels are involved, specifically small arteries and PL arteries. They believe that defective mitochondrial DNA accumulates in the endothelium or lining of these vessels, which diminishes blood flow to diffuse areas of the brain. Brain imaging studies tend to show progressive cortical atrophy in patients with MELAS. In general, the back or posterior areas of the brain are more affected than front or anterior regions. In addition, the frontal lobes and the brainstem seem to be spared. Some researchers even report the presence of migratory lesions in the brain. Research suggests that some lesions are transient, either eventually evolving into areas of generalized atrophy or resolving altogether. When this happens, new lesions in different brain areas may then appear. Although there is no cure or specific treatment for MELAS, some general treatments, although not proven to be effective through clinical trials, include things like coenzyme Q10, creatine, and phylloquinone. Overall, though, prognosis is poor. Most individuals typically die before the age of 35 from general body wasting caused by progressive dementia and muscle weakness, or from complications affecting vital organs. 20 years ago, when my nephew Cody was first diagnosed, very little was known about this disorder. There were only 2 published studies at the time, and both revealed that individuals with MELAS exhibited global patterns of deterioration. However, both studies examined a very limited number of assessment types and abilities. I therefore decided to team up with some of my colleagues to administer an extensive battery of assessments to 2 individuals with MELAS to examine how our results compared to those 2 studies in the literature. I also wanted to compare our results to what we knew about the underlying neuropathology of this disorder. So let me introduce you to the 2 patients we examined in depth, my nephew Cody and patient AJ. We'll start with Cody. Cody was my older brother's son. He died from MELAS when he was just 16 years old. Cody was a happy, normal baby, and he reached all of his developmental milestones at appropriate ages. He was always short for his age, though, which led his parents to seek the help of a growth hormone specialist. By the age of 9, Cody started to lag behind his peers at school. There was talk of holding him back a grade. Later that year, he had his first partial complex seizure, known today as a focal onset impaired awareness seizure. Doctors ran a series of medical tests to try and figure out what was going on, but the results were inconclusive. About a year later, after a series of assessments, Cody was finally diagnosed with MELAS. A muscle biopsy revealed ragged red fibers in his muscle tissue. A blood test revealed high levels of lactic acid, and genetic testing confirmed the presence of the mitochondrial A3243 gene mutation. His biological mother also tested positive for the genetic mutation, which confirmed the diagnosis. She was largely asymptomatic, though, with the exception of occasional migraine headaches. Cody's symptoms included seizures, bilateral diffuse limb weakness, occasional hearing difficulties, pronounced enough that he wore a hearing aid, left-sided hemianopsia, so visual field loss on the left, poor visual acuity, headaches, nausea and vomiting, cardiomyopathy, high blood pressure, dementia, and stroke-like episodes. Despite this array of symptoms, Cody was very independent in daily life. He dressed himself in the morning, cleaned his room and made his bed, and helped with chores and meal preparation. He enjoyed helping his dad build projects, cooking, and riding his go-kart. Cody was 13 years old when we gave him an extended battery of assessments. We tested him at home and gave him as many breaks as he wanted so that he wouldn't get too tired. He was very cooperative and happy, and he could follow instructions as long as they were broken down into smaller steps. My colleague administered the assessments, and I stayed out of the testing area as it would have been a conflict of interest given that he was my nephew. Before I tell you how Cody did on the assessments, I want to briefly tell you about our second patient, AJ. AJ was a single 33-year-old African-American male at the time of testing. He received a Bachelor of Arts degree and had been working as an elementary school teacher before the onset of his symptoms. Initially, he presented to the hospital with a partial seizure, known today as a focal onset awareness seizure. He tested positive for lactic acidosis, and the confirmation of me loss was made shortly thereafter. His only symptoms were seizures and stroke-like episodes, which just occurred out of the blue when he was in his 30s. So, how do you think Cody and AJ fared on the neuropsychological tests? Well, as it turns out, that both Cody and AJ showed severe global deficits across all of the abilities assessed. Let's start with Cody. The test showed that he exhibited deficits in basic attention and executive functioning, including problems with sustained attention, organizing thoughts and ideas, working memory, and perseveration, which means to get stuck on something. In one assessment, the examiner told Cody a story and asked him to repeat back as much of it as he could remember. The story mentioned a storm and an umbrella, which Cody remembered well. The examiner then told Cody a completely different story. When asked to recall information from this new story, Cody kept talking about the umbrella, which was actually not part of the new story. This is an example of Cody perseverating on an idea, in this case, the umbrella. In addition to these issues, Cody also exhibited deficits in visual memory, visuospatial processing, and language. Specifically, he had trouble finding words and made several semantic and phonemic paraphasic errors during testing. A semantic paraphasic error is when a patient replaces a word with another word that is similar in meaning. One of Cody's semantic errors was saying the word hammer when he was shown a picture of a saw. Though the word choice was wrong, both words were in the same category, so tools. A phonemic paraphasic error is when someone says a word or non-word that is close phonetically to the correct word. An example here is that Cody said the word swish when he actually meant squid. Cody also had difficulty with abstract concepts. If you asked him which number is more, 6 or 9, he could not answer unless you made the example more concrete, such as by saying 6 sandwiches or 9 sandwiches. Cody also showed difficulty with the encoding, storage, and retrieval of verbal and visual material, with his visual memory being more impaired than his verbal memory. His conversational speech was a strength for him, as were his graphomotor abilities, so writing. Overall, Cody's general processing seemed slow, and he had difficulty when asked to problem solve. AJ also had difficulties with executive functioning, including issues related to working memory, planning, and organization. He also exhibited deficits in visuospatial abilities, abstract thought, motor speed, and language, where he made various semantic paraphasic errors and had difficulty with word retrieval. AJ also had problems with problem solving and abstract thought, and he exhibited a condition called anosognosia. In other words, he was unaware of his own cognitive deficits. He did, however, show a relative strength in verbal memory. Cody and AJ's pattern of global deterioration across a wide range of domains is consistent with other cases described in the literature. Though, as mentioned earlier, those were based on a much smaller set of assessments. Across studies, this pattern of global deficits was observed regardless of the patient's age, which ranged from 13 to 37, or disease duration, ranging from a few months to 23 years. This pattern also seems to be specific to me loss and not applicable to other types of mitochondrial disorders, although it is likely that there would be individual differences across patients. One of the more puzzling findings is that in all cases, including Cody and AJ, severe frontal lobe deficits were observed on the neuropsychological assessments, but no frontal lobe pathology was observed on their MRI scans. The observed pathology was primarily in the posterior parts of the brain, so the parietal, temporal, and occipital cortices. Why might this be? Well, one explanation relates to the pattern of energy consumption in the frontal lobes. The frontal lobes actually require high levels of energy to function properly. Reduced energy production, however, does not result in gross neurologic or anatomic changes that can be seen on an MRI scan. This explanation is supported by post-mortem brain tissue examinations in individuals with mitochondrial disorders, which show a high percentage of mutant mitochondrial DNA in the frontal lobes. A second explanation relates to the connections between the frontal lobes and more posterior areas of the brain. The frontal cortex does not function independently. Rather, it is part of a system that involves receiving input from posterior parts of the brain. If the posterior parts of the brain are damaged, one would expect the input projected to the frontal lobes to be damaged as well. This would result in deficiencies in abilities that rely on the proper functioning of the frontal lobes. Although MELAS patients exhibit global deficits across a wide range of abilities, many are still able to perform routine daily tasks with minimal assistance, at least until the later stages of the disease. Remember that patients develop normally until the first symptoms appear. Procedural skills, such as knowing how to dress oneself, make a bed, do chores, and so on, remain intact despite the progression of the disorder. I'm hoping you now have a much better sense of what mitochondrial disorders are and how especially horrific MELAS is. To watch a loving, caring 16-year-old boy suffer and die from it is something I will never forget. In my quest to better understand mitochondrial disorders, I also ended up meeting a family where 3 people, the mother and her 2 children, were diagnosed with one specific genetic mutation associated with nucleotide 15,924. Their disorder did not have a name like MELAS, but it was associated with mitochondrial dysfunction. I wanted to examine whether symptoms and neuropsychological patterns of performance differed among these 3 individuals. The 2 kids, a daughter and a son, were the mother's only 2 biological children, and they had the same biological father. Each family member was diagnosed at a different age. Some of the symptoms were similar, but others were different. Let's start with the daughter, who I'll call DC, and who was diagnosed at the youngest age, when she was just 3 months old. DC was born 4 weeks premature. At week 2, she showed signs of respiratory distress and was hospitalized. She presented with seizures, flabby muscle tone, irregular breathing, and acrocyanosis, a decrease in the amount of oxygen delivered to the extremities. When we tested her, DC was 13 years old and in the 7th grade, homeschooled half the time. Her medical problems included chronic headaches, leg cramping, dysautonomia, including rapid alterations in blood pressure, temperature dysregulation, alterations in respiration and cardiac function, abdominal pain, muscle weakness, decreased stamina, and alterations in her menstrual cycle. She also had a mild mitral valve prolapse. The son, who I'll refer to as SC, was diagnosed with a mitochondrial disorder when he was 11 years old. He was also born 4 weeks premature. His primary physical symptom, which led to his diagnosis, was severe, almost intractable migraine headaches. At the time of testing, he was 17 years old and was in the 12th grade, and like his sister, he was also homeschooled half-time. SC's physical symptoms at the time of testing included dysautonomia, hypotension, general fatigue, and migraine headaches, accompanied by numbness, tingling, and vomiting. Finally, the mother, who I'll refer to as MC, was not diagnosed until the age of 36. MC earned her bachelor's degree in nursing and worked as a trauma nurse until she went on disability after suffering her first stroke-like episode. Since receiving her diagnosis, she has experienced multiple stroke-like episodes that have resulted in numerous hospitalizations. At the time of testing, she was 39 years old and had medical symptoms that included the stroke-like events, dysautonomia, migraine headaches, nystagmus, and lactic acidosis. A comprehensive series of neuropsychological tests was administered to the 3 participants. All 3 exhibited average to superior estimated intellectual ability and relative strengths in verbal comprehension and both verbal and visual abstract reasoning. All of them also exhibited compromises in complex attention and working memory, and they showed slowed motoric functioning in the dominant hand. There were also some individual differences between family members. For example, DC had difficulties with some of the visuospatial tasks, whereas SC and MC did not. And whereas MC had great difficulty recalling verbally learned information, neither DC nor SC did. So why would we see such disparities if all 3 family members had the same genetic mutation? Well, it may be due to a number of variables, including the specific systems affected in each person, individual patient histories, so hypoxic events, stroke-like episodes, or seizures, age of onset, and medications. Because DC and SC had undergone neuropsychological testing 8 months prior to our testing, we were able to compare their scores on some of the assessments over 2 different testing periods. And what we found surprised us. Both DC and SC showed a lot of intra-individual variability from one testing period to the other, especially on tests that examined attention and information processing, both of which are mediated by frontal and subcortical brain structures. This intra-individual variability may be due to something called executive dyscontrol. Here, patients may be very focused and performing well on assessments, but then they suddenly experience a short period of fading where their performance declines. Then they perform well again, and then they fade again. This pattern repeats itself over and over again and could explain why variability could exist when testing across different time periods. Executive dyscontrol involves crosstalk between the frontal lobes and subcortical brain structures, both of which are believed to be affected in mitochondrial disease. Interestingly, the brain scans of all 3 family members were normal. Recall from our discussion of MELAS that deficiencies in metabolic processes in the brain cannot be detected by CT or MRI scans. Researchers would need to use other types of technology, such as PET scans, to detect these types of changes. Though examining the neuropsychological profile of mitochondrial disorders is very difficult due to the many factors that must be considered, it's important work if we want to try and understand these disorders better. In addition, we can show that not all mitochondrial disorders have the same profile, as we saw with the case of the mother and her 2 children. Anything we can do to aid in the diagnosis and understanding of these disorders is worthwhile in my book. So how can we help people with these disorders? Is there any course of treatment they can take? Because we have no cure for these disorders, the goal of any treatment is to help alleviate some of the symptoms and slow down the progression of the disease. Treatment effectiveness, however, varies greatly from patient to patient, depending on the severity of their disorder and the symptoms they exhibit. Sometimes the effects of treatment can be noted quickly. Sometimes it takes months to notice any benefits. And sometimes no benefits can be observed at all. Some general treatments include prescription medications, like things for seizures, high blood pressure, anxiety or depression, and so on. Additionally, different types of therapies, like physical therapy and speech therapy, can benefit patients with motor or speech limitations. Vitamins and supplements, and even dietary changes, have also been used to address certain mitochondrial disorders. In general, it's recommended that those with a mitochondrial disorder avoid fasting, alcohol, cigarettes, and MSG. They should also steer clear of physiological stress, including both cold stress and heat stress. Patients with mitochondrial disorders have difficulty with thermal regulation or temperature control. So exposure to cold could result in severe heat loss and trigger an energy crisis. Some patients also have problems with heat. Because they might not sweat normally, they may experience heat exhaustion or heat stroke on hot days. I noticed this firsthand with my nephew Cody when he sat in the family's jacuzzi-type whirlpool spa one evening and began to show significant declines in thought processes and communication. Most of the treatments administered for mitochondrial disorders are on a trial and error basis. Sometimes they work, and sometimes they don't. Although a number of clinical trials are examining different treatments for many of these disorders, unfortunately, we still don't have any cures on the horizon. I'm hoping that today's lecture not only taught you something about mitochondrial disorders, but also made you more aware that these disorders exist and are often not immediately recognized by the medical community.